Good morning, everybody. So, as a continuation of our series in prostate cancer, today we'll be discussing about locally advanced and metastatic prostate cancer. Dr. Zarak will be presenting. I will be moderating this session. So, before we start, anybody can tell me what's the locally advanced prostate cancer? That's T3A and B, and T34 when it invade adjacent structures, or also if there is N positive, lymph node positive.
So, as it said, T3, T4 nodes may or may not be positive, and no metastasis is locally advanced, and metastatic is spread beyond the regional lymph nodes to the distant sites that may be bones or viscera. Hormonal therapy is the cornerstone treatment of advanced disease because prostate cancer remains androgen dependent in advanced stages. And androgen deprivation therapy is the cornerstone of the treatment. Okay. Initially, we'll do
What's the lymphatic drainage of prostate, Dr. Zakaula? Lymphatic drainage of prostate. It's a mnemonic, hope, hypogastric.
Initially, we'll do PSA, MRI, and biopsy. For metastatic workup, we'll do prostate-specific membrane antigen PET scan or CT scan or CT cap or bone scan if that is not available. Okay. The amicus risk stratification, we'll only be discussing high risk. That includes ISUP grade 4 and 5 or PSA more than 20 or clinical stage 2C or clinical stage T3 and T4 with or without nodal involvement, any ISUP grade or any PSA.
So this is a UASK risk stratification, or they call it also DMICO classification. Must divide prostate cancer in low, intermediate, and high risk. Intermediate is divided also in subcategories as favorable or unfavorable. So the concern of our topic today is high risk, and the subdivision of it is locally advanced, which is highlighted with the red circle.
Currently, no consensus exists regarding the optimal treatment of locally advanced CA prostate. Treatment options for locally advanced CA prostate is radical prostatectomy with extensive pelvic lymph node dissection. Okay, many patients already have micrometastasis, so surgery in T3 is controversial. In low volumes, good performance status, those patients may benefit from surgery. And the second one is radical prostatectomy followed by radiotherapy. So
radical prostatectomy for locally advanced disease. For radical prostatectomy, patient should be like a candidate should be selected very carefully. Like, the patient should have very low volume disease, because with high volume, there is chances of macrometastatic, and it will be problematic later on post-operatively, as in case of recurrence or biochemical recurrence. So these patients have to be selected very carefully and preoperatively.
radical prostatectomy plus radiotherapy. Radical prostatectomy with adjuvant radiotherapy and early salvage radiotherapy is preferred over adjuvant radiotherapy.
So what's the difference between early radiotherapy or salvage radiotherapy? Adjuvant radiotherapy you give post-operatively, no matter what. And in salvage radiotherapy, you wait till the biochemical recurrence is evident. So when there is rising BSA after radical prostatectomy, you start salvage radiotherapy.
Then there is external beam radiation therapy with androgen deprivation therapy. External beam radiation therapy is given to prostate and pelvis with long-term androgen deprivation therapy for almost 2 to 3 years. There is that significantly improves overall survival and cancer-free survival. And ADT alone is only given if the patient is frail, unfit for local therapy, or he refuses for other modalities. Okay. Classification of advanced prostate cancer. According to the EAU guidelines, it is classified into castration-sensitive prostate cancer.
Before we go for classification, anyone can tell me what's the definition of castration? Castration is reduction of testosterone by any mean, either surgical or medical, to a castrate level less than 50 nanogram per deciliter.
Now, in the West, there are certain groups of people as well as doctors and advocates, and they are known as patient advocacy groups. So patient advocacy groups, they kind of don't like this term, castration. So whenever this thing comes up, particularly in European literature, uh, these groups, they do object. So instead of using castration-resistant prostate cancer, the better term when you talk to the patient is hormone refractory. Now, hormone refractory has got the same connotation and definition as CRPC. So it looks good. It looks good from the angle that surgeons are now scientists. But once in Europe as well as in America, surgeons were actually not surgeons, they were butchers. So when you are on the other side of the table, then you can use these terms as castration. Now, castration is not a good term to be labeled as, as a kind of a procedure which is meticulously done. So when you do a procedure which is orchiectomy, subcapsular orchiectomy, then it is not castration. It has got certain standard operating procedures, certain steps to follow. You have to anesthetize the patient. You have to do anesthesia, which might be local, which might be general, depending upon your own expertise and your own protocol. But then you respect your patient. It's not butchery, right? Even butchers have got their own rights, and the animals have got their own rights. So if animals can protest, they can protest against castration. So castration is not a good word.
Right. Either it's hormonal resistant or refractory or hormonal sensitive.
Hormone sensitive prostate cancer is biochemical progression without metastasis. M1 is with high volume is more than 4 bones or visceral involvement, and M1 hormone sensitive prostate cancer with high risk is more than any of these two. Gleason score more than or equal to 8, more than or equal to 3 bone metastasis or visceral metastasis. And hormone resistant prostate cancer, there may be biochemical progression under ADT without metastasis. And high risk diseases, PSA doubling time is less than 10 months, and M1 is radiological progression despite treatment. Earlier intervention may delay progression to metastatic disease and improve overall status in hormone sensitive prostate cancer. And with metastasis in hormone sensitive prostate cancer, high volume disease benefits from combination of ADT and docetaxel or androgen receptors pathway inhibitors. So hormone resistant prostate cancer, the high risk of cases, the PSA doubling time is less than 10 months. And there is higher risk of progression to metastatic disease. And the metastasis is considered when there is radiological progression despite sufficient androgen deprivation. And PSA progression is more than and equal to 25% from nadir, with minimum rise of 2 nanogram per ml. Multiple androgen receptor pathway inhibitors, chemotherapy, radiopharmaceuticals, and immunotherapy is used during this. Okay, so this is how the hormone resistance develops in patient with a hormone sensitive prostate cancer. Initially, this is on the right side, you can appreciate, left side, you can appreciate the normal pathway where testosterone is converted into dihydrotestosterone by 5-alpha reductase inhibitors. With time, there is androgen receptor amplification, and androgen receptor mutates, and there is alternative splicing, and there is intratumoral androgen production. So that is how castration resistance develops. Sorry, hormonal resistance develops.
So there is 3 mechanism. Androgen receptor simplification, where receptors is being produced in high quantity, and also oversensitive to even low concentration of androgen. And there is receptor mutation and alternative splicing, where receptors are being produced without ligand, which is supposed to be a site for androgen the androgen attachment. This kind of mutated receptors is already innately active. And there is also sterogenesis intratumoral.
So mechanism of androgen axis blockage. We have option of orchiectomy, that is surgical removal of the testes, and inhibition of LHRH release, where we use LHRH agonists and antagonists, and there is anti-androgens, which blocks androgen receptors, and there is inhibition of androgen synthesis. Okay, so surgical castration. Subcapsular orchiectomy removes testicular tissue while preserving tunica albuginea. It can be performed under local, general, or spinal anesthesia. Immediate and permanent testosterone suppression within 24 hours, almost 90% of the testosterone reduces. It may have a psychological impact on patients. And there is no risk of flare phenomena, and it lowers the cost, and no risk of non-compliance, and no missed doses. Okay. Then the risk of LHRH agonists. They initially stimulate pituitary gland, so there is a testosterone surge for 2 to 4 weeks. Then later on, after 2 to 4 weeks, it downregulates the LHRH receptors in the pituitary and suppresses LHFSH release. Okay. The available agents.
Here, what happened, like, the LHRH is being produced from the hypothalamus in versatile way, normally. And when you give exogenous LHRH agonist, it's continuously stimulating the pituitary gland to produce LHRH. That will lead to the flare phenomena. But with the time, this LHRH receptors being underregulated and desensitized. That will lead later on to LHRH decrease LHRH in the serum later on.
So to prevent the initial surge of testosterone, which may cause worsening pains and urinary obstruction or spinal cord compression, anti-androgen cover is given for 2 to 4 before and during the LHRH agonist initiation. Okay, so what is androgen flare phenomena? As discussed, initial testosterone surge for 2 to 4 weeks, and then the testosterone reaches in the level that is below 50 nanogram per deciliter. The complications may be a worsening bone pain, urinary obstruction, spinal cord compression, and cardiovascular events. So prevention strategy is androgen cover for 2 to 4 weeks before and during LHRH agonist initiation. So high-risk patient for these are a high tumor burden, and there is symptomatic disease, bladder outlet obstruction, and cardiovascular disease. Then there is LHRH agonists. It compares
Antagonist.
okay, antagonist. Sorry, its mechanism of action is that it competes with LHRH receptors in the pituitary, immediate suppression of LHFSH release, and there is rapid testosterone reduction. The benefits are there is no testosterone flare and low cardiovascular toxicity, and the PSA declines faster in these medications. The limitations are allergic reaction, higher cost, and more frequent administration. So the ideal candidates would be those who have symptomatic disease requiring testosterone suppression, patients with high cardiovascular risk, or those with spinal cord compression where testicular flare may be dangerous for them. Okay, it is the comparison between LHRH agonists and antagonists. So the only background in LHRH antagonist is that you have to give it more frequently, monthly or daily. Other than that, it's better than LHRH agonist. Okay. Then there is anti-androgens, steroidal and non-steroidal. Steroidal anti-androgens have cyproterone, which is 17-hydroxyprogesterone derivative. What it does is it suppresses LH and testosterone and blocks androgen receptors directly. The side effects includes hypogonadism, cardiovascular disease, hepatic toxicity, and gynecomastia. Non-steroidal anti-androgen includes flutamide, biflutamide, and nalutamide. The side effects of flutamide are gynecomastia, mastodynia, GI, and liver toxicity. Biflutamide is preferred because it is more potent and it has a 6-day half-life, and there is daily dosing of flutamide requires tedious dosing, and nalutamide patient may have visual adaptation issues. The side effects include gynecomastia, GI and liver toxicity, and visual adaptation issue with nalutamide only. Okay, androgen withdrawal syndrome. This occurs in hormone resistant prostate cancer. The PSA declines after discontinuation more than to 50%. The AR mutations, as we discussed with hormone resistant prostate cancer, the mutation occurs, converts antagonists into agonists. So
what do you mean by AR? AR mutation?
Sorry, androgen receptor mutations. It occurs in patients with hormone-resistant prostate cancer who are on long-term anti-androgen therapy. The PSA decline typically is observed in 4 to 6 weeks after androgen discontinuation. And it is androgen withdrawal is considered before initiating second-line therapy for hormone-resistant prostate cancer with rising PSA.
I'm interested in one thing. Many of the residents are here and maybe the junior consultants. There has been a change in practice recently in the past, I think 5 years or so. Many of these patients are now seen separately, these particularly carcinoma prostate patients. So have you ever written the prescription yourself? Anybody from the audience can say something about it. For instance, if I ask you to write down a prescription for biflutamide, so how do you know what's the dose of biflutamide unless and until you are in the practice of writing down the prescription? Question is to the audience. Any of the residents, have you ever written down prescription of any of these drugs that have been just described in the previous slide and this slide? नहीं लिखा ना, तो आपको फिर dose कैसे पता होगी? And if you don't know the dose, how come you know the actual fallout of that drug? आपने लिखा है, आप पहले identify करें अपने आप को, कौन है आप?
So Dr. Sasi, she is attached with Dr.
ठीक है. So Sasi is actually a floater. So she floats between different departments.
I worked with Dr. Najib, that's why he used to told me that.
जी. So you see, this is the kind of, I don't know whether it is an obsession or not, but if somebody tells me, कि अच्छा जी आप तो बन गए urologist and you are an expert in maybe in any field of subspecialty of urology, and you are running a clinic, which is oncology clinic, have you known any of these drugs yourself? Have you ever been to these patients, checking out their side effects? हो क्या रहा है मरीज के साथ? तो मैं क्या कहूँगा? नहीं जी नहीं, I am concerned with only robotic surgery. I am a very robotically trained in my mind, and I take out the prostate without any कहना चाहिए क्या कहते हैं उसको, collateral damage to the nerves, and that's it. So that is not all. This is not leadership. The leadership in surgery is something different. Otherwise, फिर आपको कल को butcher ही कहेंगे ना लोग. जो हमने इससे पहले बात की थी, the patient advocacy group is actually hampering you that don't use this term castration resistant. ये सवाल वहाँ से आना चाहिए था हमारी कम्युनिटी से कि हम इस वर्ड को इस्तेमाल नहीं करेंगे. हमारी तरफ से नहीं आया, वो कहीं और से आया, मरीज की तरफ से आया कि मैं अपने साथ जो है ना बुचरी नहीं कराना चाहता. But if the butchers are wanting to be named as butchers, so what can the other party do? So please make yourself a little respectable इन द आउटर वर्ल्ड, और वहाँ ऐसे ही होता है कि हम साइंटिस्ट कहलाते हैं ना. एंड व्हेन इट कम्स टू साइंस ऑफ प्रोस्टेट और कार्सिनोमा प्रोस्टेट, then you must know all these things on the other side of the chapter. ये तो नहीं हो सकता कि हम सिर्फ एनाटमी और एनाटमी एक्सप्लॉइटेशन को ही सर्जरी समझें. ये तो है नहीं ना, कभी भी नहीं था. सो ये वाला कॉन्टेक्स्ट जो है ना, मैं शायद ड्रम अप कर रहा हूँ एक ही सुर को. और वो एड्रीनल में भी था, वहां पे भी आप लोगों ने छोड़ दिया था पिछले 5 साल में. यहाँ पे भी वही है, यहाँ पे भी आप लोगों ने छोड़ दिया. यू आर एक्चुअली लीविंग अ लॉट ऑफ ग्राउंड फॉर योरसेल्फ एंड मेकिंग योर लाइफ मिजरेबल. आप लोग आगे compete नहीं कर पाएंगे. जो लोग compete करना चाहते हैं अगले आने वाले वक्तों के लिए, तो प्लीज थोड़ा सा ना अपने आप को थोड़ा सोल सर्चिंग करें. ये सिर्फ मगिंग अप नहीं है. ये कल को आपसे कोई सवाल पूछेगा ना, जब आपको सवाल पूछेगा, आप पेपर लिखेंगे, तो सवाल आएंगे ना कि वुड यू लाइक टू डू रोबोटिक सर्जरी इन अ पेशेंट हु हैज बीन on a waiting list for quite some time and was on peclutamide because the person was on waiting list. So does it hamper your surgical technique? Answer would be what? Yes or no? नहीं, वो ना बोले जो कह रहे थे नो, वो बताएं दूसरे लोग, और भी टीम में बहुत सारे शामिल हैं. अच्छा हारिस, रोबोट को मैं हटा लेता हूँ. आपको मैं कहता हूँ कि ठीक है, यू हैव द ऑप्शन ऑफ ओपन सर्जरी और यू हैव द ऑप्शन ऑफ लेप्रोस्कोपी. देन व्हाट?
So it depends on the skills. So if you are
What happens if you use these drugs?
we will find a lot of adhesions.
Yeah. So you come to know all these things when you are into the game.
जी.
आप चूंकि पिछली जनरेशन में भी थे ना, इत्तेफाक से आप दोनों बोर्ड्स में थे, आपको पता है. आज की जनरेशन के बच्चे को पता ही नहीं है ये क्या कर रही है, इसलिए कि आपने ना सारी फाइलें किसी और कमरे में रख दी हैं. तो ये गलत हो गया ना हारिस.
जी सर.
सो यू आर नाउ द लीडर ऑफ दिस ऑन्कोलॉजी ग्रुप. सो प्लीज 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 किबला दुरुस्त करें. ये कहने वाले आपको शायद अब आने वाले वक्तों में ना मिलेंगे, किबला दुरुस्त करें. कौन कहेगा, मुझे नहीं पता.
So combined therapies approach. Modern treatment utilizes strategic combinations to maximize therapeutic efficiency. So testosterone suppression, that is castration, that's anti-androgen. It blocks the combined androgen blockage. It blocks testicular and adrenal androgens. The most common drugs used are LH, RH agonists and bicalutamide, that is anti-androgen. There is small survival benefit with suppression alone, but we still use it. Then there is intermittent androgen deprivation therapy. Androgen deprivation therapy until the PSA reaches nadir, then the treatment is paused and restart at PSA progression. There is better quality of life that includes libido erection, and there is slightly lower survival rate than ADT androgen deprivation therapy given continuously. So androgen deprivation therapy plus radiation therapy. Androgen deprivation therapy radiosensitizes tumor, and it gives a synergistic effect. The new adjuvant therapy is 2 to 3 months. Concurrent is with the radiation therapy, and adjuvant is 2 to 3 years after the radiotherapy. It is used for high risk and locally advanced diseases. It improves the overall survival compared to the radiation alone. Then there is androgen deprivation therapy and androgen receptor pathway inhibitors, plus androgen deprivation therapy and chemotherapy that we use docetaxel, or triplet therapy in which we use all three of them. It is used in high volume disease. Combined androgen blockage is repeated.
अच्छा, थोड़ा सा हम अगर पीछे चलें, आपने एंड्रोजन रिसेप्टर म्यूटेशन की बात की थी. सो व्हाट्स द फिनोमेना बिहाइंड एंड्रोजन रिसेप्टर म्यूटेशन व्हिच लीड्स टू CRPC और hormone refractory disease? So do you know what's the phenomena behind it? So in simpler terms, what it says, Amar, can you just explain?
Sir, androgen receptor mutation, there is increased production of androgen receptors which is lacking the ligand, where the androgen supposed to be attached to activate this receptor. So this is deficient and it will be indirectly active. Like directly it will go to the cell and nucleus and it will produce its supposed mechanism.
Right. So in pharmacology, what happens is we used to learn all these things when we were in medical college. That whenever a stimulus is there for which is an agonist, any kind of agonist, the receptors they tend to be down-regulated when the signal is there in any form. And when the signal is down, that is when you have the stimulus in a lower concentration, then the receptors are upregulated. So this upregulation and downregulation is what we know is through mutation. So there is a change, a transformational change at the level of receptor, and receptor is nothing but a proteinaceous structure. So it has got its own convolutional protein, makeup, and these convolutions are then changed. So this is how the whole thing goes. So if agonists are more available, then there is a down regulation of receptors and there is less stimulation. So this is the whole phenomena behind the use of agonists.
Okay. We already discussed combined androgen blockage. There is intermittent androgen deprivation, where androgen deprivation therapy is given until the PSA reaches NADID, that is typically less than 4 nanograms per ml. Then the treatment is restarted typically after 6 to 9 months when PSA rises again. So the quality of life improves with this. There is improved libido, physical activities, well-being, and fewer hot flushes.
So with complete androgen blockade, what happens is the disease becomes resistant. So it becomes hormone resistant. So with intermittent blockade, what happens is we tend to preserve the sensitivity of the organ. So it remains as sensitive as it was before.
So radiotherapy and androgen deprivation therapy. EDT radiosensitizes tumor cells and includes it induces cell cycle arrest in radiosensitive phase. So the timeline is neoadjuvant, which is 2 to 3 months after radiation, concurrent during radiation, and then adjuvant 2 to 3 years after radiation. The survival benefit is there is improved survival and disease-specific survival versus radiation alone. It is indicated in high-risk diseases, locally advanced, and Gleason score more than 8 or PSA more than 20. Androgen deprivation therapy plus androgen receptor pathway inhibitors, which is abiraterone, which is cytochrome P17 inhibitor, and enzalutamide, which is androgen receptor signaling inhibitors. These improve on the survival benefit in hormone-sensitive prostate cancers across multiple. And there is androgen deprivation therapy plus chemotherapy, which is docetaxel. Effective in high-volume diseases, it can also be used as a triple therapy for high-volume disease with androgen receptor pathway inhibitors. Indications for hormonal therapy is biochemical indicators where PSA doubling time is less than 3 months and rising PSA despite local therapy and inadequate PSA response to initial therapy. Symptomatic progression is symptomatic local progression. There may be urinary obstruction and bone pain from metastatic disease. Metastatic disease is proven distant metastasis or bone metastasis on imaging or visceral metastasis, maybe to the liver or lungs, and adjuvant settings. Adjuvant to radiotherapy for high-risk disease, extensive lymph node metastasis after radical prostatectomy. The duration is 18 to 36 months for high-risk disease. Okay. This is what we discussed. The PSA response to androgen blockage is PSA monitoring. What we do is we monitor PSA every 3 to 6 months, and the testosterone levels are confirmed that must be below 50 nanogram per deciliter, and imaging is done to see the progression. The prognostic factors are PSA less than 0.2 nanogram per deciliter, time to PSA nadir is less than 6 months, and PSA doubling time is more than 9 months. Initial PSA decline is more than 80 months. When to consider hormone-resistant prostate cancer is PSA rise despite testosterone levels less than 50 nanogram per deciliter, or there is radiographic evidence of new lesion, or the symptoms are worsening.
So how come you know that a person becomes hormone refractory? A simple test. Anybody from the audience, particularly residents. कैसे मालूम होगा कि पेशेंट है, उसको ट्रीट कर रहे थे, now the patient has become, after maybe 1 year's time, patient becomes hormone insensitive or hormone refractory, whatever you लिखा हुआ है वैसे सामने, सामने लिखा हुआ भी है वैसे, लेकिन किसी और अंदाज से लिखा हुआ है. सवाल समझे या नहीं? सवाल ही समझ में नहीं आया. अगर सवाल समझ में नहीं आया तो फिर जवाब कैसे है?
By 0.2 nanogram per ml in 6 months.
How will you diagnose it? You'll get any test done except PSA?
मतलब आप कुछ दे रहे हैं ना उसको, वो रेजिस्टेंट हो गया, वो एक्ट नहीं कर रहा, अब वो पीएसए तो रिड्यूस नहीं हो रहा, जाहिर बात है उसने ऊपर जाना है, लेकिन कोई और चीज भी है.
So testosterone level less than 50.
ये लिखा हुआ तो है भाई, मैं वो तो कह रहा हूँ, पेपर आउट हो चुका है, चीटिंग भी नहीं कर सकते यार. बात यही तो कह रहा हूँ कि अगर खुदा ना खास्ता आपने ओपीडी कर ली तो ये चीज आपके सामने आए थे, आप यहीं से पिक कर लेते. इतनी देर लगाई आपने. मैं कह भी रहा हूँ लिखा हुआ है. सब लोग ना इसको नहीं देख रहे, उसको देख रहे थे, पीएसए को. हाँ, चलिए आगे चलिए.
Complications of hormonal.
What's the best way of not having hot flushes? Oh, not flushes, but flashes. Sorry. क्या करते हैं आप जब किसी पेशेंट को स्विच ओवर कर रहे होते हैं? कुछ करते हैं? क्या मतलब मरीज आता है आपके पास, क्या कहेगा वो? आपने कभी ऐसे मरीज से मुलाकात की है कि डॉक्टर साहब आपने जो है ना मेरी सब कैप्सूलोक्टेक्टमी तो कर दी थी, लेकिन अब जो है वो मुझे कुछ फीलिंग ऑफ वार्मथ है, मतलब गर्मी तो इतनी है नहीं, मुझे बुखार भी नहीं है, लेकिन ठंड के जमाने में मुझे लगता है जैसे कि हरारत सी है. कभी किसी मरीज से बात हुई या वो भी नहीं हुई? यार मरीज तो मरीज है भाई, वो कभी तो देखोगे, वो आएगा तुम्हारे पास ही. या तो चैप्टर फाड़ के फेंक दो अपनी किताब में से. मतलब ये सवाल के जवाब अगर यहाँ नहीं दोगे, इम्तिहान में कैसे दोगे? इम्तिहान तो छोड़ो, बस जिंदगी का इम्तिहान तो बड़ा इम्तिहान है. वो बस लिखा हुआ भी है, वार्मथ इन अपर टॉर्सो हेड, मतलब पता नहीं क्या क्या और अलावा अलावा बहुत सारी लिखी होगी. मैनेजमेंट भी लिखी हुई है वैसे. ये भी नहीं पढ़ सकते. कितना रहेगा भाई? आप लोग वैसे थोड़ा सा कोशिश करें पढ़ने की, और मैं आपसे क्या.
So this guideline recommendation, we have almost already discussed them during the presentation. I think it's almost
My call.